I'd like to welcome everyone to our webinar, Embracing Social Media in Research. For those of you who are interested in receiving accredited continuing education credit, the Northwest Association for Biomedical Research and Quorum Review are co-sponsoring a conference on July 23rd at the Bell Harbor International Conference Center here in Seattle. The topic will be Revolutionizing Informed Consent. This conference has been approved for CME and CNE continuing ed credits. You can register and learn more by visiting the websites that are listed. Also, Quorum is debuting our new service called SiteMatch. SiteMatch helps sponsors and CROs find the right research sites for their studies by using custom criteria tailored to the protocol. Quorum has relationships with thousands of sites and institutions, and we can help you find the right match to optimize the site selection process. And now I'd like to introduce today's expert presenter, Dominic Chiarelli, one of our regulatory attorneys here at Quorum Review. Before joining Quorum, Mr. Chiarelli worked as a regulatory analyst and an IRB member with Seattle Children's Research Institute, where he was also a member of Children's Intellectual Property Group. Mr. Chiarelli earned his Juris Doctor from the University of Washington and is a member of the Washington State Bar Association. Additionally, Mr. Chiarelli is a registered patent attorney and a member of the Washington Patent Law Association. And now I'm going to transition the slides over to Dominic.
Thank you, Ari. Hello. It's a pleasure to present to you today. Despite all that attorney talk, I hope you can see that I'm a kindred spirit. I worked in cancer biology and genetics for 5 years, and I've got a real respect for the bench and the bedside and all that science has to offer. Let's briefly touch base on the agenda and what I hope you take away from this webinar. First, what is social media and why it is important? Second, how social media can and is being used in research. Third, the regulatory and legal framework governing recruitment and how it relates to the use of social media. Fourth, what IRBs look for when reviewing social media content, and finally, best practice tips for creating a research social media plan. I have included anecdotes and examples throughout to try and make this presentation as interesting as possible. No small feat when discussing human subjects regulation. We also have 2 poll questions today, and so be ready to think critically once prompted. Without further ado, let's jump in. First things first, what is social media and why is it important? Social media is a product of our most recent historical revolution, the information age. The way in which we learn, communicate, and even trust information has fundamentally changed as information of all types has become more freely available. In this new age, we are more connected to each other than ever, but somewhat ironically, in-person communication seems to be becoming less and less frequent, and dare I say important. What this means for medicine, and in particular for research, is not entirely clear, but I'd like to make the argument today that the information age, and specifically social media, has the potential to make research more efficient, more meaningful, and potentially even more personal. What is clear is that medical information is no longer as concentrated in medical providers and that the public is actively seeking medical advice from the web. Clinicians are still the prime resource for obtaining health information, with the majority of U.S. adults getting their medical advice straight from a doctor or other health professional. The trend, however, is that people are more and more interested in using online resources to make their own conclusions regarding their health or to check the advice they're receiving from their providers. A good example of this shift, which is quite controversial, would be the effect of vaccinations on the health of children. You can find reams of information on the web from purported experts as well as lay people regarding the lack of value for immunization, and you have parents making decisions regarding their children's health without consulting their physician or even regardless of what their physician may say. Another example of this trend would be gluten sensitivity and whether it's really a medical condition. The medical community largely does not think so, but based on my Facebook and Instagram accounts, it seems that quite a few of my friends do. 2 numbers on this slide really jump out at me and reinforce the idea that the web is starting to compete as a source of medical information with providers. The first is that 72% of internet users have looked for online health information in the past year. That's an extremely high number and will likely only increase as we spend more and more time on the internet. The second is that 18% of internet users have gone looking for others with similar health concerns. I find it surprising that 1 in 5 people are actively looking for somebody with a similar condition to presumably share their experiences with. Apparently, gone are the days that a diagnosis was a carefully guarded secret with family, friends, and providers. Instead, people seem to be turning to websites like Patients Like Me and Dave's Friends and to social media to expand their knowledge of their condition or the available treatments and to reach and connect with others for support and a sense of community. So what is social media? Social media is loosely defined as an interactive platform for electronic communications used by groups of people to create, share, and exchange information. At its core, social media allows people to identify and connect with others in real time and for little to no cost. It is this ability to identify and connect that has given social media its significant potential for influence, which can occur without and sometimes even in the face of, more traditional institutions or even methods of communication. After all, social media and its ability to reach and align has already been attributed with numerous groundswells that have led to real outcomes, like the toppling of oppressive governments or placing Stephen Colbert's name on a NASA treadmill. In the context of healthcare, a good example of social media's ability to identify and align the public into a potent groundswell is the recent Save Josh campaign. Have you heard of this? Josh Hardy was a 7-year-old boy with recurrent cancer, who in his latest rounds of chemo had developed a viral infection that couldn't be treated using approved drugs, without potentially also ruining Josh's kidneys. Josh's doctors knew of an experimental drug that could potentially be used to successfully treat him, and had requested access to the product on a compassionate use basis. The company declined due to concerns over the stage of drug development and the plan to submit for marketing approval in the near future. After a couple of weeks and Josh's continued decline, the family decided to create a Facebook page dedicated to saving Josh. And with a little help from prominent organizations, more than 1 million people had viewed Josh's story within 48 hours. The company immediately began to receive intense media scrutiny and decided to contact the FDA to discuss their options. The decision was to open a new Phase 3 protocol that allowed children, and specifically Josh, to participate. This trial was approved and ready to enroll within 2 days of starting talks with the FDA. Josh enrolled in the trial, received the experimental medicine, recovered from his infection, and continued with his chemo. Based on what I've seen from social media, he's now apparently in remission and doing quite well. This was all made possible by social media and its ability to create communities dedicated to a cause and to give that community a clear and unified voice. Social media's potential to reach and align is so exciting because one of the principal issues confronting the development of new therapies is a lack of eligible participants. Poor recruitment and retention increases costs, delays timelines, and leads to inconclusive results. The competition for trial subjects has only become more intense as studies have become larger, longer, and therapies have targeted more rare populations. Take the following facts. It's sobering to consider how few people actually agree to enroll in clinical research. The numbers are exceedingly low, even for people with poor outcomes. It's amazing to consider that poor enrollment is tolerated as much as it is when you factor in just how much time and effort a clinical trial requires. It's been reported that each day a drug development program is delayed sets the sponsor back up to $40,000 in operational costs and up to $8 million in lost opportunity costs. And finally, it's disheartening to realize that half of all Phase 3 trials never reach a quarter of their accrual goal, even with all this effort. This last fact may be the worst of all. A trial that is unable to answer its aims has unnecessarily exposed the participants to the intervention's risks of harm, has arguably wasted the participants' time, effort, and goodwill, and perhaps even made the participants ineligible for other current and future trials. Clearly, our recruitment efforts can and should be improved. Enter social media. Social media is cheap and ubiquitous and can be leveraged to extend the reach of research. It can also, perhaps, even be used to align and build highly engaged communities interested in particular treatments or conditions. And because it's interactive, social media can help with recruiting, retaining, and even collecting data. The number of users alone is staggering and suggests access to the public that was previously not possible by brick and mortar methods. With this amount of activity and the trend towards healthcare moving online, it's not really a question of whether social media will be useful, but why you haven't already started using it. Despite this potential and the seeming inevitability of social media, the research community has been rather slow to adopt it as a research tool. The question is why? The general feeling that I gather is that discretion is the better part of valor. I believe this is due to a lack of several certainties surrounding social media's use. I hope to address some of these uncertainties today and to provide you with firm recommendations that you can use going forward. We do not have time to touch on each of these concerns individually, and so our focus will be mostly on the IRB review and approval piece. That said, these points are all related, and by understanding what's required for review and approval, many of your other concerns will also be addressed. I will, however, quickly acknowledge that in terms of enforcement, the FDA is watching social media rather closely and in fact issued several warning letters in 2014 regarding what it considered to be inappropriate uses. I do not want to make it sound like I believe social media is easy and everyone should just be doing it. There's no question social media is complex and that discretion is warranted, but in my opinion, this should simply not take it off the table. Let's conduct a quick poll for what you think is the #1 reason that adoption of social media has been slow. We will provide you with several possible answers and give you a few moments to consider your response. Well, let's look at the results. I'm glad that you don't think social media is unnecessary. If you did, I'd be concerned about how we approached advertising this webinar. And I'm reluctantly glad that there's some confusion out there about the technology and what needs to be submitted, because I think this webinar will help you. We asked this question of our sites, and the responses we got were very interesting. Here is some data from our own recent survey of research sites and their use of social media. It appears that it is about a 50-50 split in regards to who uses social media, with Facebook being the primary social media chosen. We also asked what was the primary reason why sites had not used social media previously. The most common response was that sites did not need social media in order to recruit based on tools or databases that they had already developed. But we also heard, ranked in order, a lack of resources to pursue social media, special privacy concerns with social media, or a lack of institutional support. I was pretty surprised by the belief that social media is not needed, and I presume this is mostly the sentiment of sticking with what you know. A bird in the hand, after all, is worth two in the bush. The literature I've seen all suggests there is a need to boost recruitment for clinical research, and that social media, as a new and hip technology, can help fill this need by its fantastic reach and ability to span a wide range of demographics. So speaking of age, let's turn our attention to an old friend, the Human Subjects Regulations. There is no doubt that social media pushes and even potentially exceeds the boundaries of the Human Subjects Regulations. The ethical codes and resulting regulations were all considered and published way before the Internet assumed its prevalence in everyday life, and none have been updated in any meaningful way to address the recent advances in technology. What we are left with is the broad principles of human subjects protection, which do not necessarily lend themselves easily to the many specific questions that social media presents. What we need is more granularity and specific examples of how social media should be handled from a human subjects protection standpoint. This would normally be the role of federal guidance, but unfortunately this has also been sparse to non-existent or only tangentially related. The most relevant research guidance we have was issued in 1998 and concerns the recruitment of participants using television, radio, and receptionists. This guidance is, in fact, almost detrimental to the cause. It's a very conservative in laying out what requires prior IRB review and approval, and essentially treats all newer methods of communication as if they were print materials, which they are not. There's been other guidances as well about the use of clinical trial websites, but again with little actual benefit to understanding where new technologies may fit within the human subjects protection landscape. That is until recently, when the FDA issued 3 draft guidances concerning the appropriate use of the Internet in the promotion of approved products. It's important to note that none of these guidances are specific to research, and the legal rationale supporting them are based not in the control of investigational products, but in the promotion of approved products. However, that said, I would wager that the FDA's thinking with regards to research will not be all that different. These guidance documents address 3 specific areas: presentation of risk-benefit information, correcting misinformation, and how to keep the FDA sufficiently aware of your activities. The main takeaways are: the limitations of a chosen social media platform, in particular character limitations, cannot excuse publishing information that may appear misleading or that overemphasizes the possible benefits from participation. Manufacturers retain responsibility for any communication under their direct control, and if choosing to respond to inaccurate or misleading information, the response must be tailored, accurate, and clearly attributable to the manufacturer, and manufacturers must provide the FDA with a description of all anticipated social media uses, including clear identification of each platform and annotated screenshots demonstrating the look and feel for all social media interactions. It is not clear if or when the FDA will issue guidance specific to research. In the meantime, we have taken cues from the ethical codes, the regulations, and the guidances to help inform what we believe is a reasonable and cohesive approach to social media, which I'd like to share with you now. At Quorum, we have tried our best to embrace social media as a potential good and to understand and appreciate how it can facilitate the clinical research process. So what we've tried to do is take a common sense approach that applies both the letter and the spirit behind the human subjects regulations. This approach all starts with defining what is an activity that is or should be subject to IRB review. What we have settled on is that our review should be limited to only those communications that have a clear intention to recruit or retain participants for a specific clinical trial. We have labeled this content reviewable subject matter. The result is that there is a fair amount of content published on social media that would not require our review. For example, news stories, celebrity tweets, and peer-reviewed articles published on a Facebook page for a Parkinson's trial would all not be reviewable. None of these materials are specific to a clinical trial activity, and the intent is to foster participant engagement, not enrollment. We could choose to review these materials, and I'm assuming some IRBs do, but we have chosen not to. One reason is that if we required review, this would likely reduce the use of these types of materials, and from what we understand, participants really appreciate them. The second reason, which is in line with FDA guidance, is that it's difficult to make the argument that reviewing such materials would provide any additional protection to participants with regards to their rights, safety, or welfare. Now that we know what we review, we should talk about our standards for review. The main focus of our review is whether the information provided could be considered inaccurate or misleading as presented, in particular with regards to the stated possible benefits and the likeliness of a favorable outcome. This standard is strictly enforced. Therapeutic misconception is already prevalent in research, and the likelihood of this misunderstanding is arguably greater in social media, where further context is often lacking. This is because social media usually has limitations on text or format that reduce the communication to only one narrow aspect of the research. Words are consequently at a premium, and each word must be carefully chosen to ensure the communication has its intended effect, raising interest in a clinical trial, but that it does not go over the line. This is a very fine line to walk. The biggest offender we see is the word treatment, which implies benefit if it cannot be further explained. But we also see examples of communications that inappropriately focus on payments or free medical care or are simply overly optimistic. What do you think about the example provided here? Is it acceptable to describe an online survey study as potentially leading to a big medical breakthrough? This leads us to our next poll question. Which of the following communications would be allowed? We will give you a few moments to take a look, have a think, and then respond. You guys are very sharp. Answer number 3 is the correct answer. Each of the 3 other communications presents information that is either inappropriate, inaccurate, or misleading. It's interesting to note that a statement like answer number 4, new treatment for diabetes, may be appropriate in a consent form, but not necessarily in social media. The reason for this is that once again, context is very important to combating therapeutic misconception. Here, the lack of additional context that this treatment is, in fact, investigational, makes the term treatment arguably misleading and crosses the line of what we consider meaningful participant protection. Uses of social media should be submitted like any other participant material. Documentation is required for everything in IRB reviews, and so this means submission of hard copies or final mock-ups of all communications that qualify as IRB-reviewable subject matter. This includes all study-specific homepages, posts, tags, and ads. As I'm sure you can imagine, this can end up being a lot of content. Thankfully, however, after initial review, new and reviews content can usually be reviewed as a minor modification using the expedited review process, and so new posts or changes to approved posts can be quick to turn around and implement. Quorum also generally wants to see any other information that will be readily available to users, and in particular, account profiles. Most, if not all, social media platforms out there allows account holders to provide information that explains the account itself. What we're looking for is that participants are able to easily identify the purpose of the account, how to be managed, and any limitations on how it should be used. Facebook is perfect in this regard, in that it allows for both a long and short description of the account and study, and for expectations to be appropriately set. In particular, that the account should not be taken as medical advice, and that study-related events should be reported to a study doctor as soon as possible. We also generally hope and strongly recommend that a comprehensive social media management plan will be developed and submitted for review. These management plans are great for providing a complete picture of how all social media activities will be conducted and for providing standards for what will and will not require prior IRB approval. One thing to note with recruitment and social media in particular is that if you develop a management plan, you can seek IRB review and approval for your social media activities independently of the review and approval for a particular protocol. This can go for both sponsors and sites, and it's a great way to ensure you're meeting industry expectations for participant protection. This plan and how they're reviewed is similar in concept to what's required for e-consent, which may be more familiar to you. Since a management plan is so important, and not knowing where to start is one of the main reasons researchers have not adopted social media, let's turn our attention to best practices for developing a social media management plan. Ideally, a social media plan will include rationale for each use, an explanation of how the privacy and confidentiality of users will be protected, a process for vetting all communications for appropriateness and the need for IRB review, and a predefined approach for handling user-generated content. If such a plan is submitted, you are much more likely to sail through IRB review, will have to commit less resources to ensuring continuing review, and will hopefully have a very engaged research community on the other end. Let's touch on each point briefly, starting with rationale. Each use of social media should be supported by rationale justifying the use. The most common rationale, and one likely sufficient in most circumstances, is that the clinical trial needs to boost recruitment, and the target demographic heavily uses a particular social media platform. For example, a trial for breast cancer would likely benefit from a comprehensive Facebook campaign. The depth of rationale required will generally depend on the study itself and the characteristics, familiarity, and reputation of the social media platform. Facebook, for example, requires little rationale as it provides many options that help ensure the risk to participants can be minimized, is widely used by the public, and has a fairly good reputation. Twitter, on the other hand, may require little more rationale as it offers less privacy protections, is not as widely used, and is generally viewed as more truthy than Facebook. Any privacy protections that will be taken should be also carefully considered and explained. Generally speaking, all communications provided and received through social media should be presumed to be identifiable and public unless specific measures have been taken to ensure their privacy. The challenge is that the different social media platforms all have very different capabilities in this regard. Facebook allows for the creation of pages or groups and for specific privacy and notification settings within each. A page is largely public but can be set up so all user-generated content is disabled or reviewed prior to being shared. A group can be public, private, or even secret and can be set to be invitation only. Twitter, on the other hand, defaults to a completely public setting and does not allow for user-generated content to be disabled or even filtered. Twitter does, however, allow for direct messaging and for protected tweets that are only available to pre-selected users. All communications should be vetted for their appropriateness, regardless of whether they require IRB review. This is best accomplished using a formal plan, and perhaps even a committee to review and approve all communications prior to their use. As a model, you could look to a data safety monitoring plan, which contains predefined rules and a diverse committee of people of varying expertise. The main concern should be whether a communication could cause an unintentional consequence, and in particular, a harm, be it psychological, social, economic, or legal. Unfortunately, with social media, there are many examples of rather well-intended communications backfiring on the originator. Have you heard of Starbucks' recent Race Together campaign? It's a great example of a well-intentioned idea that became a public relations nightmare and potentially even harmful to Starbucks and Starbucks patrons. How would this post be received on a Facebook page for a prostate clinical trial? Probably not well, even if the article provides good information that is likely of interest to followers. Similarly, how would this post look in your teenager's newsfeed? It could present some negative connotations for them with their peers or with parents of their peers. All communications should also be vetted for whether they require prior IRB review and approval. This is one of those times where a formal management plan can save reams of time because if you can identify what you will and will not consider IRB reviewable subject matter, the IRB does not need to review each and every communication that you produce. For Quorum, we again limit our review to only those communications that are tied to a particular clinical trial in which the intention is to recruit, retain, or collect information. All other communications do not require IRB review, although Quorum would generally expect that these communications would be described by category with examples in the social media management plan. Once a communication goes out, users of social media have the opportunity to respond. This user-generated content is considered essential to a robust online community. However, it can offer a unique challenge in the context of human subjects research. The traditional model is that all formal communications must be IRB reviewed and approved prior to their use. But in the world of social media, this may not be possible due to the unpredictability of what the communication may need to be. The easiest solution is to disable all user-generated content, but this potentially compromises the community. An alternative solution is to put specific measures in place that describe how user posts will be monitored and the actions and/or communications that can be taken as necessary to ensure participant protection and study integrity. These measures can then be reviewed and approved by an IRB, and thereby can occur without additional review or perhaps with reporting to the IRB afterwards if it was necessary to deviate from the approved materials out of the best interest of the participant or to eliminate an immediate apparent hazard. For example, a rule could be in place that a Facebook page will be checked daily for possible adverse events, and if one is identified, it will be immediately documented and escalated to a medical monitor for review. It will then be removed or clearly addressed by the host as soon as possible using pre-approved language and a private message sent to the user directing them to report all study-related events to their study doctor. This is certainly the most tricky part of using social media, but there are some good resources out there related to pharmacovigilance that can be used to help inform development of a good monitoring plan. The final point that I'd like to briefly make, which does not necessarily concern IRB review, but does concern the effectiveness of using social media, is that all uses of social media should be integrated with each other and with a dedicated clinical trial webpage. Social media is great for reaching participants, but that message has to be directed back to a meaningful filter in order to be effective. This can and should generally take the form of a dedicated clinical trial website in which all relevant information about the clinical trial is available. This site would ideally also have the functionality to screen for eligibility and to locate participating clinical research sites. A comment that we have heard is that if you do not filter participants, social media can significantly raise your rates of screen failures and potentially set your sites back and not forward. So let's briefly discuss what social media may look like moving forward and then quickly summarize. Social media is only going to become more prevalent. Based on recent data from the Pew Research Center, the number of people using social media is increasing, the frequency in which people are using social media is increasing, and the number of people using multiple social media sites is increasing. I trust you can see the trend is an overall increase in social media. If you combine this with the earlier numbers regarding people looking for health information on the web, I think it's fair to say that social media in medicine and clinical research is here to stay. I can also say from Quorum's perspective, we have definitely seen much more interest in social media and have been receiving more and more requests to discuss possible strategies as well as the availability to review standalone social media campaigns. These have come from both sponsors and sites, and we look forward to continuing to learn from our clients as they continue to innovate and raise awareness around their activities. Social media can do much more than simply recruit. It could also become a manner for consenting participants, collecting data, and potentially returning results. Truly, the future may already be here with the recent excitement around HealthKit and other studies involving social media like Genes for Good. It looks to be soon that social media will become much more than just an opportunity to build engaged communities and actually become a method for conducting the research itself. We at Quorum have also seen a significant uptick in interest regarding new uses of Facebook and Twitter, like Twitter chats, promoted tweets, and social media listening, the use of other social media platforms like Pinterest, Instagram, and YouTube, and also the use of interactive e-consent platforms and data collection apps. All of these are fair game for improving participant recruitment, retention, and hopefully the overall research experience. And I know at Quorum, we're excited to see what the future holds for the e-participant. As I hope I've drilled home, social media should really only ever occur when you have a plan in place. A good plan will address at least the rationale for its use, any privacy concerns, the process for vetting communications, and how user-generated content will be monitored. A good plan should also help to ensure that your communications are relevant, integrated, and lead participants to more complete information about the trial and possibly even screening. Quorum does not offer a model template at this point in time, in case you're wondering, but I hope you can get the gist from this presentation, and I encourage you to contact us if you have further questions or would like formal help in developing your own plan. I'm an advocate for social media because I believe it can be used to improve the research experience for participants and thereby improve the recruitment and retention of participants as well as the outcome for all patients. In particular, when used well, social media can help to build communities, reach participants, develop more direct relationships, and improve the overall reputation and awareness regarding research. I actually think these last 2 points have been, unfortunately, a little lost in the social media conversation. Social media gives the research community an opportunity to communicate directly with participants and to highlight all the care and dedication that in fact does go into clinical research. At times, I get the feeling that clinical research is not well understood by the public and that a cynicism exists that clinical research is only about money and not about improving human health. I am confident, however, that if the public got the opportunity, like I do, to regularly learn from, interact with people working in clinical research, that this feeling would be replaced with more of an optimism for the promise of research and the good people working in it. At least I hope that's the case. With that, I'd like to thank you for your attention and turn you back over to Ari.
We hope that you did find this topic informative and useful, and if you are interested in learning more about Quorum, please visit us at quorumreview.com. We also have several resources available at quorumreview.com resources. You can sign up for our newsletters, view past webinars, and also read industry-relevant articles on our blog, including a few on social media. You can also connect with us on LinkedIn, Twitter, Google+, YouTube, and SlideShare. And on behalf of everyone here at Quorum, we thank you for attending our webinar and hope you enjoy the rest of your day.